Of course, if you guys have any questions, please let me know. So remember we talked about calculating the pH of, in most cases, drugs. We're gonna see how important this is in Block 4 when we look at pharmacology. But in order to calculate the pH, if you were given the hydronium concentration, what you would do is just plug that number of hydronium molarity into your calculator, and you should come up with this number here. And again, as I mentioned before, a shortcut is to just take the negative log of this first number, negative log of this first number here, and then subtract it from 3, because we know negative log of 3 is 3. So are there any questions about calculating the pH? Yeah. No? Okay. We talked about arterial blood gases and their importance as well. Of course, this assay is measuring our body's metabolic functioning, and it's evaluating the body's pH, the carbon dioxide levels, and the bicarbonate levels in the body to ensure that the body is maintained at its proper pH. This equation is very important for determining arterial blood gases. Carbon dioxide plus water in the presence of carbonic anhydrase will produce carbonic acid that will quickly dissociate into bicarbonate and hydrogen ions. This is the foundation for our body's maintenance of its proper pH. Any questions? All right. Remember, when calculating arterial blood gases, you need to know the normal parameters for pH, partial arterial carbon dioxide, and the bicarbonate levels. Remember, carbon dioxide is reversed, meaning that the higher number indicates a lower pH, and the lower number indicates a higher pH. So this is very important, and I recommend you guys remember this and have this written down once you guys start the exam, so you're able to calculate the arterial blood gases. In addition to the compensation table telling you what the values mean and whether or not partial, full, or no compensation is occurring in arterial blood gases. So remember the tic-tac-toe method. I would use this to set up your equations or your calculations. We're looking at arterial blood gases. If you follow what we talked about in class, starting with pH, then moving to carbon dioxide levels, and then bicarbonate, and using this compensatory table, you guys will get all those questions right? Any questions? All right. We talked about in the last block, how important the hexomonophosphate pathway was in order to get us NADPH, and then we extended that in this block, looking at how NADPH is used to reduce glutathione. Glutathione is very important for scavenging free radicals in our body that are produced by a number of things. We talked about how APAP is metabolized by 2 pathways, the phase 2 glucuronidation and sulfation that produces a non-toxic product that's just excreted from our body. But in phase 1 metabolism, which it's metabolized by which cytochrome P450 enzyme? Say it again. 2-echo-1, exactly. 2-echo-1. It produces a very, very toxic NAPK, which is N-acetyl parabenzoquinonamine, and that is hepatotoxic. So if we run out of glutathione, which would scavenge that, then we would give N-acetylcysteine, and N-acetylcysteine would interact with the NAPK to produce a non-toxic substance that is then excreted in our this is that pathway broken down into more detail. So again, APAP metabolized by conjugation, phase 2, to produce water-soluble conjugate. By phase 1, it's metabolized into NAPK. If we don't have any glutathione or any N-acetylcysteine, that's going to cause hepatonephrosis. But if we have glutathione or NAP, that will interact with NAPK to produce a non-toxic substance that is excreted in our urine. All right. So another toxicological emergency that you guys will likely see in practice is the overdose of acetylsalicylic acid or aspirin. And basically, bottom line up front, you guys would treat this with activated charcoal, which will do what? Absorb it, right? And you can use IV fluid resuscitation and bicarbonate. And in severe cases, you might want to have the patient undergo hemodialysis. And this enzyme, the enzyme that metabolizes aspirin, is cytochrome P452-9. We talked about carbon monoxide as another emergency that's used. Probably we see that in cases of suicide or in cases where people don't want to barbecue in the cold weather. And so what that does is that basically causes the hemoglobin to bind to the carbon monoxide, which of course decreases the amount of oxygen that is able to travel throughout the body. And this mechanism of action of carbon monoxide is it reversibly binds to the heme A3 copper center, preventing oxygen from binding in complex form. And so what that's going to do is that's going to disrupt ATP production. It's going to shift our metabolism into anaerobic metabolism, and then we're going to see lactic acid buildup, which will cause the patient to have metabolic acidosis. Questions about that? Cyanide treatment, hydroxycobalamin or sodium nitrite or sodium thiosulfate. That's the take-home message from this slide. Those 3 treatment modalities for this condition or this poisoning. And again, cyanide also interacts with the electron transport chain. It irreversibly binds to iron, which inhibits iron from interacting with the heme A3 portion, inhibiting electron transfer. All of this too is happening in complex 4. So again, no ATP or less ATP production, and you'll see metabolic acidosis because of that lactic acid. All right. We talked about cholesterol synthesis. Cholesterol synthesis is very important. The first step is acetyl-CoA plus acetyl-CoA, and the rate-limiting reaction of this pathway is catalyzed by HMG-CoA reductase, and this is where statin drugs act as competitive inhibitors of HMG-CoA to eventually stop cholesterol production. This is what statins are doing. They're inhibiting cholesterol production, which is the main treatment for patients suffering from hypercholesterolemia. And here is the key pathway steps for cholesterol synthesis. Remember, this process occurs in the cytosol of the cell, and the HMG-CoA enzyme must be dephosphorylated in order for it to become active. And it is dephosphorylated by insulin and thyroxine T4, and when it is dephosphorylated, it's able to go on to produce more cholesterol. some hormones and regulators that phosphorylate this enzyme, rendering it inactive, are glucagon, epinephrine, and increased levels of cholesterol. As we see in this pathway here, HMG-CoA reductase is, when it's phosphorylated, it is inactive. Insulin and T4 will dephosphorylate it, and that will render the enzyme active and enable it to produce cholesterol levels. So in addition to these regulators, there's also another regulator of this enzyme, and that's the SREBP2 regulator. And what this regulator does is that when cholesterol levels are high, it is a transcription factor. So it will cleave from the Golgi apparatus, travel into the nucleus of the cell to stop the transcription and translation of HMG-CoA reductase, and that's when cholesterol levels are high. And it does the opposite. When cholesterol levels are low, it will cleave from the Golgi apparatus to cause HMG-CoA to be produced, and therefore to produce cholesterol. Yes.
All right, 2 questions about the pathway for the SREBP2. So high levels of cholesterol will reduce that being cleaved from the Golgi apparatus and not allow for the increased transcription, and then less cholesterol will cause it then to go to the nucleus.
So high levels will. What did I say? So if cholesterol levels are high, this SREB2 will basically cleave, and it's gonna this SREB2 is gonna go into the nucleus and block the transcription and translation. So either way, it's going to interact with the nucleus to either increase or decrease the transcription and translation.
Okay.
Does that make sense?
Yeah, so high levels of SREBP2 in the nucleus will reduce transcription of HMG-CoA reductase.
Yes. Yeah.
Okay. And then when the transcription is happening within the nucleus, the HMG-CoA reductase comes out from that translation as active, or does it come out as the inactive form?
It comes out as active.
Active form. Okay.
Any other questions? So we talked about how statin drugs were competitive inhibitors, meaning they're structurally similar to HMG-CoA, and these drugs will end with the suffix statin, and they are metabolized by cytochrome P453A4 or 2C9. What's also metabolized by 2C9 aspirin, right? So basically, they're gonna decrease cholesterol in those patients that have high cholesterol levels, and if we have too much statins in the body, then they may cause side effects such as muscle pain, fatigue, and muscle breakdown in severe cases. And these drugs, remember, they're modulated by things that we take for other conditions, such as we drink grapefruit juice. We take St. John's wort for like a mood enhancer, and then red rice yeast is also another herbal supplement that we might take. And so grapefruit juice will basically cause the increase of statins in the body, and so that's going to produce the potential side effects that we see. Red rice yeast has a similar effect in that there's a molecular structure, a molecular component of red rice yeast that has a similar chemical structure to statins. So if you're taking statins and red rice yeast, it's equivalent to having too much statins in the body. And so again, potential negative side effects. And then St. John's wort is going to cause increase activity of 3A4, which then is going to decrease the amount of statin levels in the blood. So you're not going to have the therapeutic effect that you need if you are taking statins in addition to St. John's. All right. Any questions about that? Yes.
So for the grapefruit juice one, is that one decreasing the enzyme effects of the CP?
Yes. Yes. Thank you. Cytochrome P453A4 is inhibited by grapefruit juice. So basically, that means that if you take statins, there's nothing to break it down. So there's going to be increased level of statins to cause the potential negative side effects. Yes.
And then for the side effects, it's if you are taking too much statins, that's what it's gonna cause?
Yes. Yeah. Or there's too much circulating in the blood. Yeah. Any other questions? All right. This is a big pathway, but we're gonna break it down. So remember, this is pathway for steroidogenesis. We talked about how cholesterol is the precursor for all steroid hormones. It's metabolized into pregnenolone and the glomerulosa, which produces mineralocorticoids, aldosterone, 17-alpha hydroxylase will shunt that pregnenolone into fasciculata, which produces cortisol, which is a glucocorticoid, and then 17-20 lyase can shunt this pathway to produce androgens and estrogen, which are sex hormones in the zona reticularis of the adrenal gland. So, other key important elements in this pathway are, we talked about DHEA, which basically is used to help treat excessive cortisol levels, adrenal fatigue. It kind of balances out the negative effects that we see from cortisol. And then we talked about aromatase converting androgens into estrogens. Aromatase are used in estrogen receptor positive cancers and postmenopausal women to basically decrease the amount of, so this aromatase decreases the amount of estrogen, so estrogens cannot interact with the estrogen positive receptors to facilitate cancer cell or tumor growth. So we also talked about congenital adrenal hyperplasia, and what that condition is the deficiency in one or more of these enzymes, 21-alpha hydroxylase, 11-beta hydroxylase, and 17-alpha hydroxylase. So we saw if there was a deficiency in 21-alpha hydroxylase here, that would be a decrease in mineralocorticoids, also a decrease in cortisol, shunting the pathway to this direction, so there would be an increase in sex hormones. That makes sense, right? Then for 17-alpha hydroxylase shown here, if this enzyme is deficient, that's going to increase aldosterone, which is a mineralocorticoid, and it's going to decrease both the cortisol and sex hormones. Now 11-beta hydroxylase was a little bit different. We saw that this enzyme here, if this enzyme is deficient, there is going to be a reduction in cortisol, so there's going to be an increase in sex hormones, but we saw paradoxical increase in mineralocorticoids, and that is due to compensatory mechanism from our pituitary gland causing adrenocorticotropic hormone to be produced, because the pituitary gland senses that cortisol levels are low. When that occurs, this steroidogenesis pathway in general will be increased, and what will happen, there will be a bottleneck increase of intermediates in both of these pathways, but particular corticosteroid, which is also called DOC, and DOC has mineralocorticoid activity. So DOC basically is able to interact with receptors, mineralocorticoid receptors, thus simulating the effect of having an increase in mineralocorticoids. Does that make sense? Yes.
So in reality, the one that's circled, the mineralocorticoid of aldosterone is down, but since we have a different one, it's taking its place.
Yeah, essentially this one, since we can't produce aldosterone, this has enough activity on the mineralocorticoid receptors, and since it's a bottleneck is so much of it, it's basically simulating increase in mineralocorticoid hormones. Does that make sense? Yes.
So when we're studying this chart, is it, like, I guess sufficient for, like, the questions that will be asked to, like, understand the relationship in the top chart, or should we be knowing those intermediate hormones and then rate them?
So, great question. So understanding this, and also, I wouldn't say you need to know this table because there's a lot of information, but how can I put this without giving the answer? In one of the quizzes, I asked for an intermediate of one of these pathways. You remember that? So, not saying you know the intermediates, but you know the suffix name, then you will know how to answer the question. If that makes sense. Does that make sense? Yes, no, somebody? Okay. Good question.
Sir,
Yes.
I guess I'm kind of like confused as to why 11 beta hydroxylase would decrease cortisol but increase sex hormones. So it would shunt it towards,
Yeah.
but then wouldn't some of it go to cortisol also?
It can, because it's blocked. The cortisol, like this
Oh, I
is the
see.
enzyme
Okay.
that produces
Gotcha.
cortisol. So it's gonna shunt it this way, and then when adrenocorticotropic hormone goes and increases this pathway, you're gonna get all these intermediates, but this one is active on these receptors. Yeah. That makes sense. And I was just saying that what happens when there's we can't produce cortisol, so this hormone is gonna stimulate the increase of this pathway here, and you're gonna have intermediates of all of this. This intermediate is active, almost as active as this one. So that's why you have that paradoxical increase in the. Does that make sense? All right, we're still in the adrenal gland, but now we're talking about catecholamines. So we know that catecholamine synthesis starts with tyrosine, and tyrosine hydroxylase is the rate limiting enzyme of catecholamine synthesis pathway. We also know that there's a number of other important intermediates in this pathway. Tyrosine hydroxylase will produce phenylalanine and DOPA. DOPA in melanocytes can produce melanin by the enzyme tyrosinase, and then, or it can produce dopamine by dopa decarboxylase, which will then produce norepinephrine and epinephrine. Tyrosine can also produce T4 thyroxine, and in another pathway, it will produce homogentisic acid by homogentisic oxidase, and this acid will then go on to become fumarate, which, as we know, is an intermediate or byproduct of the urea and Krebs cycle. Right? So, what's the most important thing? What's one of the most important things about this pathway?
regulate.
Right, okay, good. And this is just the pathway for that, the key steps in that pathway. And so if there are any enzyme deficiencies in the catecholamine pathway, then we will see some disorders. We talked about phenylketonuria, albinism is a result of tyrosinase deficiency in melanocytes. Homogentic oxidase causes alkaptonuria. And then dopa decarboxylase, this is not a disorder, but it is the target of the drug carbidopa, which inhibits this enzyme in order to allow dopamine to circulate in the brain a little bit longer in order to decrease the side effects that we see in Parkinson's syndrome. So the star biochemistry, phenylketonuria, we know that this is a disorder caused by phenylalanine hydroxylase deficiency. It leads to phenylalanine buildup and also the phenylalanine acetate and those toxic products that can lead to intellectual disabilities, musty urine odor, and so we treat this by a diet low in phenylalanine, so it bypasses that step. Albinism, that is characterized by a lack of melanin, and that again is due to tyrosinase deficiencies, and so this is going to cause light skin, light hair, light eyes, and also vision problems, and so there's no cure for this condition, so you would want to ensure that your patients are taking care of their skin and eyes, UV protection mainly. Then for alkaptonuria, this is caused by homogentic oxidase deficiency, leading to homogentic acid buildup, which causes the urine to be dark upon exposure to oxygen, causes that ochronosis, which is the black pigment in the connective tissue, and so you would treat this condition by diets low in phenylalanine and tyrosine. Any questions about the catecholamine deficiencies? And so we talked about the methionine and methionine cycle. This is one of two sulfur-containing amino acids, and this methyl group in methionine is critical for methylation and DNA and protein synthesis, and it's involved in substrates like S-adenosylmethionine, which is the body's universal methyl group donor, and other intermediates in that pathway, in addition to producing cysteine. And here is the methionine cycle pathway steps. And we talked about that here with methionine being converted to S-adenosylmethionine by methionine adenosyltransferase and ATP. That methyl group is the primary methyl donor in the body. That's coming off here. Methyltransferase converts SAM to S-adenyl homocysteine, which is then converted to homocysteine, which can then go on to produce cysteine. When there are enzyme deficiencies in the methionine cycle pathway, we see conditions that are involved with connective tissue and intellectual capabilities. And so one of the conditions is due to a defect in the cystathione beta synthase, and this causes homocystinuria. So you can treat this by vitamin B6 and some other vitamins as well, folate and betaine, and you would decrease the methionine in the diet. Another methionine metabolic disorder is a deficiency in methionine synthase reductase. This enzyme ensures that methionine synthase stays in the active form, providing reduced vitamin B12 to the enzyme. And again, any deficiencies in the enzymes in these pathways, you're going to see the potential for intellectual disabilities because these enzymes or this pathway is involved in DNA and protein synthesis. Yes.
So for all these diseases, it's saying like the CVS, CGL, and then the MTRR. It says it's the defect. So the defect of that enzyme is what causes the disorder.
Yes.
Okay.
Yep. And so you would treat this deficiency with vitamin B12 and folate and also methionine as well. Cystathionuria is caused by cystathione gamma lyase deficiency. Now, this is one of the few deficiencies in this pathway that you may not see intellectual disabilities, and that's because this, so if we go back, this, so here is where the cystathione gamma lyase, this intermediate is not, when it's built up, is not as toxic as homocysteine, and so that's why the patients that have this disorder will usually present as normal, but they may have intellectual disabilities, but likely they won't. And so you would treat this by vitamin B6. As you know, vitamin B6 is the cofactor for that pathway, the transsulfuration pathway in general. All right, any questions about that?
You're saying cystathione buildup is not as bad as
Homocysteine buildup. Yep. And here's the key steps to the folate pathway. Now, the key takeaway from the folate pathway is that this 5-methyltetrahydrofolate is important, and it connects the folate cycle and the methionine cycle. And it does that at this step here, where the 5-methyltetrahydrofolate will donate that its methyl group to homocysteine in the presence of B12 and methionine synthase to regenerate that methionine. So this is how these pathways are integrated. Yes.
Sir, so if you were to ask us about the methyl donation, and you said the folate cycle, that would be SAM, you wouldn't consider the 5-mother effer donating a methyl to be a part of the whole? Sorry.
No, I appreciate that, thank you.
So if you were to ask us, like, what donates a methyl group in the folate cycle, it would be SAM. And if you were to ask us in the MET cycle, the MBT cycle, it would be the 5.
Correct. Good
Okay,
question.
so it's not
Yes.
like considered like 2 donations happening in the folate cycle?
No,
Like one in
no,
each?
yeah, it's one of each, yeah. And I wouldn't, if the question is asked, it would be very clear which pathway I'm talking about. Any questions? And if there is a folate deficiency, of course, we're gonna see neural tube defects. That's what I remember from general biology 30 years ago when I was in college, neural tube defects. And also megaloblastic anemia. Again, these pathways target DNA synthesis, and the deficiency or defect can be caused by a number of different things as listed here. And so you would treat this folate deficiency with vitamin B supplementation in general. So basically all of the vitamin Bs that we talked about. And then there are drug interactions with folate. Basically, these drugs either block the folate pathway or they inhibit absorption of folate, and you won't need to know them in any level of detail. If you see a question, then you would just need to know that these drugs interact with the folate cycle. You will learn more about this in pharmacology and substance. So the megaloblastic anemia that is resulting from folate deficiency basically it inhibits the DNA synthesis pathway, it disrupts the G2 phase of mitosis, and so you're gonna see large immature red blood cells, megaloblasts, and hypersegmented neutrophils, as shown here in this picture. So large immature red blood cells and hypersegmented neutrophils. Any questions? So, heme synthesis, we know heme is a major component of hemoglobin. Heme is also a prosthetic group for the cytochrome P450 enzyme and a number of other enzyme systems in the body. And so in this pathway, this involves basically multi-organelle steps, so it occurs in the cytosol and mitochondria of liver and bone marrow cells. You see it's blocked by iron at two key enzymes, by lead, at two key enzymes, aminolevulinic dehydratase and ferrochelatase, which will cause some presentations in your patients. And then if some other enzymes, uroporphyrogen decarboxylase is blocked or decreased, that will cause porphyria cutanea tarda, and then porphobilinogen deaminase decrease will cause acute intermittent porphyria. And so those conditions will present differently. So make sure you know the differences between the presentations of lead toxicity and these two enzyme deficiencies. All right. And we talked about the coagulation cascade, which consists of three pathways: the intrinsic pathway, extrinsic pathway, and the common pathway. And many of these steps in the pathway use calcium and phospholipids for activation. So what activates the intrinsic pathway? Exposure to collagen, correct. Why?
Negatively charged.
Negatively charged, absolutely. What about the extrinsic pathway? Don't get shot, remember? Don't get got, don't get shot. So yeah, so that means when your blood vessels are exposed by external injury, and so that's gonna expose factor 3 to the blood, which is normally not exposed to the blood, and then that's gonna cause the extrinsic pathway to be activated. All right. Questions? We talked about the different, yes.
For that, are we gonna have to know how warfarin and heparin are like in this pathway? Or do we just have to know that warfarin's treated for extrinsic pathway and heparin is treated for?
Correct.
Okay.
Sorry, it would be beneficial for us to know each of the names of each of the factors in this.
Not some of them had Hageman factor and all that. No, don't know that. Just know what the factors are doing, and if you know the pathway, just generally how the steps come together for the common pathway you asked me. Oh, is there another question? Okay. All right. So we also talked about the biological warfare agents and how they are classified and grouped in biosafety levels, 4 different levels, each level nested into the subsequent level. each level having a certain amount of containment and certain requirements in terms of protective gear, and also where each level, what some examples of each level. So most importantly from the biosafety levels is knowing which levels generally what risks they have for their effects on the population. And so we know BSL level 1, very minimal risk. E. coli is an example, and that's found in our digestive tract. We also talked about the CDC's classification of biological warfare agents. We talked about 3 different category A. You guys only need to focus on these 3, and knowing what how they present in patients, knowing the major symptoms, if there's any treatments or vaccines, knowing that information. So for anthrax, what's the general class of drugs that treats anthrax? Antibiotics, exactly. Stuff like that. All right. What about botulism? What treats botulism? See, I'm on this. Good. All right. For category B, we talked about ricin and staphylococcal enterotoxin B. And so, is there an approved vaccine for ricin? Nope. Right. What about for SCB? Nope. What's the treatment for SCB? Supportive care. Absolutely. Good. You know all this stuff. And then finally, category C, we talked about hantavirus, and is there a treatment for hantavirus? Nope. Good. And then here's just a summary of those. Now, in you guys' chart, I copied the wrong slide in there, so it might be it's missing the plague, isn't it? No. Okay, yeah, sorry about that. It's on your lecture where we went over this, but make sure you don't forget about this and stuff. For that. You guys have any questions for me? Yes.
Going back to the met-folate cycle integration, MS and MTR is the same thing, correct? Like the same enzyme? Because I saw in the methionine metabolism disorder,
Which
the
one?
MTR for the MS, what is it? The methyl.
Methionine synthase.
Correct. Yes. And then MTR is shown on the methionine metabolism disorder.
No. So they're related. So MTRR interacts with methionine synthase in order to give it reduced vitamin B12 in order to regenerate methionine. So they're not the same, they're different enzymes.
So what is MTR?
It's methionine synthase.
Okay.
Yeah.
So it's the same thing.
Yeah. Yeah, sorry, yes.
Okay.
You would just need to know, if you see it on the exam, I'll fix that. It'll be
MS.
MS.
Okay.
Yeah.
Thank you.
Any other questions? Yes.
Just to confirm, he said we don't need to know the names of the clotting factors?
Like Hagman factor and all that stuff? Correct. Yes. Any other questions? I mean, you guys can learn it if you want to. I just do.
Sorry, going back to the polling at those 2 cycles. Biggest thing is just that, is it transferring the full 5 MTHF to the other cycle, or is it just the methyl group?
The methyl group is being interacting with homocysteine to produce methionine.
It's just the methyl. It's not the whole MTHF?
No, it's just this methyl group.
Just the methyl. Okay.
Any other questions? All right, if you guys have any questions? Yes.
So I have one just about the SREP2. So on your
The who?
the the SREP two
Yes.
for cholesterol. On your slides, it said that low levels of cholesterol are gonna activate the SREP two, and then that's gonna inhibit the translation.
Yes, did I say something different when I explained it?
For the review, you said that high levels of cholesterol would activate SREP two, and then that's gonna inhibit translation instead of activate translation.
I'm sorry, say that one more time.
For the review, you said that high levels of cholesterol are gonna activate the SREP two, and that's what's gonna inhibit translation, preventing the synthesis of the HMG CoA reductase.
But the slide says something different.
Yeah, like the note section of the slide says that when cholesterol is low, SREP is activated to increase the enzymes in cholesterol synthesis.
So when cholesterol levels are low, SHREB will decrease cholesterol synthesis. It's going to decrease this HMG CoA reductase.
Okay.
Is that what I said, or did I say something different?
Yeah, that's what you said. Yeah, for the review. It's just notes on the slides for the lecture say that it increases it instead.
I'm sorry, I don't understand.
I can touch base with you after.
Okay, and I'll clarify that for you guys. I don't want to tell you any more information. Are there any other questions? If you guys have any questions, you can. My office is 1319